Good morning, everyone. Welcome to Neurology Grand Rounds. On behalf of the department, it's my pleasure to introduce Dr. Harish Choudry, who will be speaking to us today about stroke rehabilitation. Dr. Choudry is Assistant Professor of Physical Medicine and Rehab, Associate Residency Program Director, and Director of the Inpatient Rehab Service here at SUNY Downstate. He completed his undergraduate education and medical school at the University of Oklahoma, followed by a Master of Public Health in Health Policy and Management at the Johns Hopkins Bloomberg School of Public Health. He then served as attending physician at Rutgers University before joining the team here at Downstate. Dr. Choudry is interested in inpatient stroke rehab, musculoskeletal rehab, and orthotics and prosthetics. He's most passionate about medical education in PM&R and has revamped his residency didactics over the past year, also reaching out to a neurology program for collaborative lectures and hands-on sessions. So without further ado, I'd like to welcome Dr. Choudry to share his expertise on this very important topic.
Okay. Hi, everyone. Glad to be here to talk to you. I sent out a PowerPoint that's very extensive and thorough, kind of for you guys to use as a reference, but I'll skip over some parts and try to focus on what might be the best facts to take from this lecture. So my idea here was to cover I imagine you guys get in a couple of situations where you want to talk to your patients about what their possible outcomes could be for recovery from a stroke, some predictors, and then patients will often ask you, what kind of rehab am I going to do when I go to rehab? And you might not always have the answer. So I'll show you some of the older techniques, some of the newer things emerging. And this way you guys could maybe better speak with and educate your patients about the rehab part of stroke. So the big thing, as all of you as neurologists know, is there is a lot of disability after stroke. People will be significantly impaired and a lot will end up institutionalized in nursing homes, even if they're severely impaired. And what the patient's family and society wants in general is for a return to their previous lifestyle and finding ways to lessen the burden on caregivers, their social support systems. There's major risk factors for disability after a stroke, a lot of things that are kind of make sense when you think about it: the severity of the stroke, the comorbidities, the level of consciousness, aphasia, their previous functional status, incontinence as well. And about 50 to 70% of stroke survivors will regain functional independence to some degree after a stroke. And there's a lot of different predictors, things like the type of stroke distribution, their cognitive and communicative impairment, the comorbidities, their ability to cope, their social support system, and the kind of rehab they receive afterwards as well. So there's been a lot of different research studies into this. I put them in here for those of you that are interested to go through and see. But the biggest takeaway is that the most reliable and consistent predictor of a patient's functional outcome during rehab is what their functional ability was at admission to rehab. Basically, if someone, let's say, is hemiplegic versus someone that has anti-gravity, the anti-gravity person is going to be have a better outcome for their rehab. And then right hemispheric strokes do more poorly than left, mainly due to a lot of cognitive impairment, neglect, and whatnot. Important things to know are that return of tone will usually precede distal control, and mass movement patterns or synergies will precede specific isolated coordinated motor functions. And there's an estimate that about 1 in 10 stroke patients are functionally independent at the time of the stroke, but at 6 months, almost half gain independence. And this next slide has, along with this one, some of the major impairments for people in percentages for your review. And at the end, kind of what it comes down to is the time course for recovery is variable, but most people see the most improvement in the first 3 to 6 months. Although later recovery is possible, it's important for people to focus hard on their recovery in those first 3 to 6 months. So getting them to the right place, getting them motivated and engaged as well. These are later for review, the different types of strokes and outcomes. But a big thing to remember is incontinence is a very poor predictor, along with a persistent hyperglycemia as far as worse outcomes for recovery post-stroke. So in conclusion, for this section at least, there's a lot of variables that can help you predict the outcome, but the big thing is every person is different. The first 3 to 6 months is where the majority of recovery will come. The higher they are functionally at the time they're going to rehab, the better their outcome is likely to be. And then this slide, I think, might have the best use for you all, is these are some easy things to see that predict outcome. Is so complete arm paralysis at onset is associated with poor hand function post-stroke. Absent grip strength by 4 weeks post-onset is associated with poor outcomes, and severe proximal spasticity is associated with poor outcomes, and a prolonged period of flaccidity is associated with poor rehab outcomes. So it's pretty easy to see if someone's hand is flaccid, spastic, if they have no hand grip, and if those things are they're present, it could indicate a poor outcome of recovery. This is just recapping again that slide with the major risk factors for disability post-stroke. So we get into stroke recovery, the mechanisms and theories as well. So there's many different ones. There's local processes like the resolution of edema, resolution of ischemic penumbra, resolution of remote functional depression, things like diastasis, and compensation. Compensation, it can be a good thing early on. It's not necessarily bad, but there comes a tipping point where patients are over relying on them and need to start working on utilizing the affected side. They need to challenge their compensation techniques. Unmasking is another method of recovery, along with collateral sprouting, and neuroplasticity is the big thing. So, the reorganization of the CNS to help with recovery. And neuroplasticity is a thing that's utilized a lot for recovery and stroke rehab. So there's 10 principles of neuroplasticity listed here. A couple of kind of easy ways to remember it. So it's kind of like you have to use it or lose it. You use it to improve it. The training needs to be specific, and repetition does matter. Intensity matters. The time you do it matters. Salience matters. Your age matters. Transference matters, and interference matters. And this doesn't just apply to like stroke rehab. If you're trying to make the NBA, probably got to learn how to shoot 3-pointers, and all this would kind of apply as well to that, if you want to think of it that way. So general timeline of recovery for stroke from a study done in Denmark. Mild strokes, you'll see recovery about 6 weeks, moderate 10, and severe 13 weeks. Very severe ones at 15. So knowing those kind of timetables might be helpful for you all. And then getting into stroke rehab. So the primary goal of stroke rehab is functional restoration to maximize independence, lifestyle, and dignity for the patient. We want to help them figure out their goals and work towards those to achieve them. Ideally, it starts within 24 hours of the stroke, if possible, on the stroke unit, and once medically stable, getting them transferred to a rehab facility to continue their recovery. So most recovery of deficits occurs in the first 3 to 6 months. And if someone's still severely disabled about a month post-stroke, it's a generally reliable proxy for their final outcome. So there's stages of motor recovery, which are helpful to know kind of where your patient is at and where they're progressing to. And tone will precede voluntary movement. Mass movements are preceding isolated movements. And an important thing to remember, because this comes into the types of stroke rehab later, are the Brunstrom stages of motor recovery. And, these are things you've probably seen firsthand with a lot of your patients. Is initially there's a flaccid period, followed by basic synergies and minimal voluntary movement. They start to get more voluntary movement with an increase in spasticity. And then as they start to get out of those synergies, they'll have a decrease in spasticity, progressing towards normal function eventually. And I find this graph to be pretty helpful for visualizing that. So flexor synergy is most common in the upper extremity and extensor synergy in the lower post-stroke. I put in a couple of slides for you all just to see the common patterns there. And so motor recovery, commonly you'll see arm before leg as far as affected, and then recovery leg before arm and proximal before distal. So prognosis for motor recovery, full recovery, if it occurs, usually is within the first 3 months, minor recovery from 3 to 6 months. And if there's significant partial return, recovery may last longer. So again, that's that 3 to 6 month timeline of the majority of your recovery. Poor prognosis for recovery, similar to the Twitchell indicators from earlier, will be no recovery within 3 weeks. Motion in one segment is not followed by motion in another segment within 1 week. And so if they have some recovery in the first 4 months, there's about a 70% chance of good recovery. Poor prognosis for return of arm function is complete arm paralysis, no grip strength at 4 weeks, and no graft spreading, severe proximal spasticity, a prolonged flaccidity period, or late return of proprioceptive facilitation. Patients often want to ask, will I be able to walk again? And about 80% of stroke survivors will recover the ability to ambulate short distances without assistance, but less than 50% achieve limited community ambulation, which is about 150 feet. If they regain lower extremity strength to grade 3 out of 5 within 1 week following stroke, the likelihood is that the patient will walk. But an important thing to remember is the quality of that walking is not necessarily fully returned. A lot of these people, they'll fail a 6-minute walk test. They're unable to deal with environmental barriers. Their speed is much slower after the stroke. Vision as well can be affected, but if the hemianopsia doesn't improve within 3 weeks, there's a poor prognosis for recovery. And perceptual functioning, the greatest amount of recovery again is in the first 3 to 6 weeks, 3 to 6 months. For aphasia, recovery is slower than motor recovery, and it kind of depends on the size of the lesion, but can be more variable. And for aphasia, the recovery is greatest improvement in the first 2 to 3 months after onset. After 6 months, there's a drop in rate of recovery. And dysarthria, again, is another big impairment for patients, and recovery of swallowing function in most brainstem strokes will happen within the first 3 weeks. Within 7 days, swallowing function recovers for about half of the patients. So getting into rehab interventions, there's a lot of different settings that can be done in the acute care facility, acute rehab hospital like here at Downstate, SNF or SAR, outpatient or at home. And there's a lot of different problems that have to be addressed on top of the neurological problem for these patients. The important thing is first preventing another stroke, but things we look to address as well are their incontinence, depression, nutrition, spasticity, communication, seizures, pneumonias, pain, fatigue, DVTs, dysphagia, preventing falls. And so most patients on the hospital side and into the acute rehab or subacute will be on DVT prophylaxis up until time of discharge to home. Pneumonia is a common thing, especially with people with brainstem strokes. So looking out for it, screening for it, making sure we're using appropriate compensatory techniques to avoid it. Aspiration pneumonia, bladder dysfunction. So persistent urinary incontinence is associated with a poor outcome. So we try to come up with a toileting plan for these people, both for bladder and bowel, and ways to eventually help them recover. They may need outpatient workup. But one important thing to remember is with bowel function, fecal incontinence is the worst prognostic indicator post-stroke for recovery. And nutrition and hydration, getting kind of our nutritionists on board early is one thing we do, but making sure we're addressing their caloric intake needs and helping them to stay hydrated, well-fed, motivated. Pain can be common afterwards. Shoulder pain can be due to many different reasons. Patients can have subluxation They can have pain due to loss of external rotation. They can have spasticity, could be rotator cuff tendonitis, plexopathy, could be complex regional pain syndrome or adhesive capsulitis. So a good physical exam trying to differentiate it, getting appropriate imaging and treating the appropriate diagnosis is important. Then depression is often a big thing. It's very hard for people to adjust to their impairments post-stroke, and motivation is a big part of their recovery. So that's one thing I at least try to focus on with them. I think finding that setting small goals that are achievable helps people work towards bigger goals as well. And there's different medications that can be given to help recovery. Things like amantadine or fluoxetine, levodopa or bromocriptine have shown evidence, as well as dextroamphetamine. And medications that can impair, the biggest ones being things like benzodiazepines help, in certain ways with certain things, but in patients with TBI, stroke can impair cognitive and functional recovery. Patients also will often have questions about, I guess, life in the bedroom, and appropriately counseling them is the thing that comes up from time to time. And fall prevention is the other big thing, making sure patients are either aware of their limitations or in a place where they are in view of the nursing station, have a bed alarm if needed. When we see falls most often is patients start getting recovered, start getting overconfident and think they're capable of some things they aren't, and will end up falling because they've overextended themselves. So this is the area I wanted to get into more. So is the different kinds of rehab therapies, at least the thinking behind them and the types. And what ends up happening, a lot of it is that therapy ends up being a mix of many different things, but there's principles behind and thoughts behind a lot of them. So there's the traditional therapies that started in the past that have been combined into many different things. Things that focus on range of motion, strengthening, mobilization, and sensory stimulation. So a common one is the Brunstrom technique. And the thing with Brunstrom is it wants to incorporate these primitive synergy patterns into the adaptation and motor recovery for these patients. So they're going to progress from gross movements to controlled movements. So this is moving and doing the therapy in the synergy pattern. Basically, you can see the gross movement, then they on the top go towards maybe a little more fine. Bobath therapy is the opposite of Brunstrom. So they want to inhibit the primitive patterns of movement. They want to encourage you to break from these synergy patterns. And a hallmark thing of Bobath therapy is you'll see often this Swiss medicine ball incorporated into it. So the goal is to suppress the abnormal muscle patterns before then introducing the normal patterns. You want to avoid the mass synergies for the patients. Again, opposite of what Brunstrom was advocating for. And then proprioceptive neurofacilitation. The goal is to use spiral and diagonal movements rather than the traditional movement in the cardinal planes of motion. And it facilitates movement patterns that have more functional relevance rather than strengthening individual muscles. And not on this slide, but the next one. Okay. So here's an example of some PNF exercises. These are things patients can do on their own pretty easily using their unaffected side to move their affected side. So we often will encourage patients that when they're not in the therapy gym to do these in bed or while sitting up in the chair to further work on their recovery. And patients are pretty motivated and pretty easily able to do these ones. So rude cutaneous motor stimulation. The idea is that things like superficial stroking, joint compression, quick stretching, icing, tendon tapping, or vibration or fast brushing gives facilitatory or inhibitory inputs to the muscles, and it's going to promote contraction of these muscles. So here they're using an ice cup. That's a massager at the top. This therapist is compressing the joints, and then on the bottom right, stroking the muscle to try to stimulate it. And then motor relearning, or what makes more sense to call it, is functional training. So work on functional training to accomplish specific functional tasks, teaching the patient to problem solve and attempt new tasks as they're able to. And it's kind of based on the cognitive motor relearning theory. We want them to learn skills that will be useful to them when they're discharged, and we focus on specific tasks or goals. So for traditional therapy, it's usually a mix of these different things done together. Someone might start out in the gym where they do cutaneous sensory stimulation before working on Bobath therapy with their synergy patterns, and then eventually some PNF exercises progressing to functional training for a full 90-minute therapy session. So it'll be incorporating and kind of adjusting specifically to that patient what you want to do. And then there's a lot of newer stuff going on in therapy, and I'll start to cover some of that. Some requires a lot of resources to do, some is not covered, but has been shown to have some support for patients. A lot of these newer ones, the idea behind them are they can supplement and extend the time in therapy on top of one-on-one with the physical therapist. They could be things a patient could do on their own as well. So rehab technology can be like apps, devices, tools used to deliver higher intensity therapy in a shorter period of time, or longer periods of time. This is not so new. It's a commonly used thing as constraint-induced movement therapy. So forced use is the principle behind this, that repeated use of the hemiparetic extremity will bring about improved function. So you want to constrain, not restrain. So like you see this gentleman has a mitt on, but it's not tied to the bedpost. So by constraining his unaffected side, he's forced to use his affected side and regain function faster. You don't need to use a sling. A padded mitt is usually good enough, and remind the patient to not use the good side unless it's an emergency. Another thing is partial body weight supported ambulation. So this kind of gets towards functional also. If you want them to get better at walking, helping them walk. And this allows patients that might not have the balance or muscle strength to do functional walking. So they get into a harness over a treadmill, are partially unweighted, and attempt walking, maybe with a therapist helping them to try to walk in a normal gait pattern. There's mixed evidence on this. It's been shown maybe to help walking speed and the gait, but not necessarily to have significant improvement over traditional therapy, but further research is ongoing. And this would be some examples of it. You can see the therapist is very close on hand to help guide them and adjust as needed. It can do things like increase their exercise capacity, decrease their energy expenditure, increase endurance, and increase motor recovery. But again, the evidence is mixed, is what these slides are basically getting into. And then functional e-stim, so thinking to improve the voluntary movement by using an electrode pad to stimulate the muscles. Kind of a drawback is the benefits don't persist when stimulation is discontinued, but you'll activate the PNS through neuromuscular electric stimulation. And some technology that's interesting, and you could work towards some of your patients in the outpatient setting if you're interested, would be functional e-stim with things such as a BINS or walk aid for foot drop. Basically, an electrode will go over the calf, and it has even a positional sensor in the new ones, and it'll deliver an electric stimulation at the appropriate time to bring them into dorsiflexion and have a more normal gait pattern. This just goes into kind of how it works a bit, but the patient needs good knee control is a big part of this. And then for wrist drop, BINS has one as well. So stimulation can bring them into extension and promote closing of the hand as well. Cool technology in the process of getting covered by Medicare, Medicaid, but not currently covered. And then electromyographic biofeedback is another thing. So having the patient doing therapy while being able to see EMG activity ongoing. So giving them awareness of their muscle activity or lack of it, and helping to help them cognitively, I guess, understand and work towards more concentrated contractions. Mirror therapy, a bit in stroke rehab, a little more in spinal cord injury and amputees is where we use it. Mirror is placed in the mid-sagittal plane, reflecting the non-paretic side as if it was the affected side, and the patient will do movements with both hands while their brain is basically understanding it as seeing two normal sides rather than one affected side. And then there's been robotic support devices that have come out as newer technology that can help basically provide passive or active range of motion and assistance in therapy. These powered devices can have an influence on the user by supporting their posture and movement, coordinate their movement as well, things like exoskeletons or end effectors. So this would be an exoskeleton. If any of you rotated some of the VAs, you might see it in use with spinal cord injury patients there as well. And this would be like a robotic support device that's peripherally there, helping move the hand through different movements as well. And there's sensor-based or pressure-based devices as well that can encourage them to visualize and see as well their grip strength. Virtual reality, the new thing, digital environments created by computer software where the users can interact and react with different realities to get feedback. It can be engaging, it can be motivating. It's upfront cost is a bit, but then inexpensive afterwards. It can be used by the family or patient outside of therapy hours. And here's some examples. If any of you are familiar with Oculus, there at the bottom right, that's where a lot of these have kind of progressed towards being. And, there's computer environments that there's ongoing research that shows it can be effective and it can be easily understood by patients even of older ages. And then there's apps, software that can help patients track and motivate. It can give videos of exercises to do as well. Help with things like language aphasia to different degrees. And a couple other just modalities would be like motor imaging, bilateral arm training, or non-invasive brain stimulation. Ultimately, we get to, we have certain things we want, and the biggest is ambulation. So we want to encourage patients to ambulate as soon as we can and to be bearing weight as much as they can. And we'll use devices to help them, things like walkers, hemi-walkers, canes, seldomly forearm crutches or axillary crutches, but more commonly a hemi-walker, rolling walker. Trying different surfaces, barriers like stairs, and proprioceptive training. And then orthosis is needed for foot and ankle drop or wrist drop are commonly used. These can help ambulation, promote more normal gait patterns, and helping the patients with their ADLs with adaptive equipment using many different methods. Just here, there's some different devices that are commonly used for patients. And wheelchairs if necessary, at least while on the rehab units, every patient gets a wheelchair. An important thing maybe just to take away for you all is for most patients, the wheelchair will clear the ground for their feet. But in severe hemiplegias, you lower the seat 1 to 2 inches so they can propel with their strong arm and leg while keeping the affected one off the ground. So I tried to think of a way to kind of break down most of the rehab simply for you all. And the general idea for a lot of this is, so you want to reduce, this applies MSK, neuro, a lot of different things. You want to reduce inflammation, reestablish range of motion for the patient, help them recover their strength, then work towards proprioception and balance before getting into practice or functional situations and then a real world execution. The easiest example for this, I think everyone has twisted their ankle and is familiar with recovering from that. So in bringing down your inflammation, there's RICE, rest, ice, compression, elevation, reestablishing your full range of motion. Everyone tells you after you twist your ankle, keep it moving, don't let it lock up. So working to get that range of motion there, and then reestablishing strength, focus strengthening, weight bearing is tolerated. It's important that you get your full range of motion so that you're not strengthening in a limited range, and then at end ranges you would be weaker. And then work on proprioception and balance, things like, balance boards, uneven surfaces for your ankle stability, and then returning to practice, like with a graduated practice plan, before going back to playing in a game. So I think that all makes a lot of sense to people there. So if you're looking at that similarly for stroke rehab, that reducing inflammation is secondary stroke prevention, optimizing them medically, controlling the blood sugar, blood pressure, cholesterol, then helping this person reestablish their range of motion. We need to make sure, they're not spastic, that we're able to range them fully, working on strengthening that affected side before progressing to proprioceptive training, and then functional training before they're ready for discharge home or that real world situation. If any of you are interested, I just put this in. There are neuro rehab fellowships. Dr. Spar in your program, I believe, did one at Burke Rehab. He might be a good resource if you're interested in that. And also, if any of you are interested, there is a 2-week elective in PM&R for neurology residents. It's focused more on interventional pain and musculoskeletal sports, but if you're interested in having it geared towards inpatient to some degree, we could adjust it as well. So you can talk to Dr. Kirk or Dr. Agarwal about that. And that's it. If you guys have any questions, feel free to ask now, or you can email me. And I don't control the insurance off, so don't ask me that one. That's the one thing I gotta say.
Harris,
Yeah.
how you doing? Excellent job. You really covered it all. Just a couple of quick questions. The first one is acute versus subacute. That is the question, to paraphrase Shakespeare. One of the problems I've had since coming at downstate is a little push and pull. Some people are pushing towards subacute, some people are pushing toward acute. How do you decide who's going to do well with acute versus subacute?
Yeah, so there's a couple of things that play into it, but the biggest thing at the end of the day, I think a lot of it comes down to cognition and social support. For a lot of our patients, their social support is different than people in other parts of New York, I guess, is a tough thing. The goal for most people is to have them at least minimum or contact guard by time of discharge. And if they have enough social support, that's a pretty reasonable thing for going home. If you're trying to estimate someone's recovery, they usually say about 2 levels. So if someone is max assist, you would project they go up from max to moderate to minimum assist in about 2 to 3 weeks on acute. And if they have good social support, that's a good level for going home. That's just some basic stuff. The other thing would be, someone can be very well functionally, but cognition can be a problem, maybe safety awareness or something like that. So finding out what they have as far as they're going to get certain hours of home health versus the family member at night is going to be able to be there. That takes a little bit of teasing out and the beginning to find out. I would say ultimately, we want to get people to the right place for them. And I think acute helps a lot more than subacute for their recovery. So I am willing to give people chances, even if towards the end it might be a little more difficult for them and they might have to go to subacute. I think the intensity early on of acute works better for them. The big thing is ability to participate in 3 full hours. That's like a mandate from the government, or else they'll be denied for it. So again, cognition and motivation, I guess there is another thing to look into.
And a corollary question is how much pushback do you get from insurance companies when the patient comes in that needs a little bit more time? For example, like a right hemispheric stroke, they have a worse prognosis because they need more time. If you keep working with them, they actually do fairly well. How much pushback do you get to finish the job
Yeah,
according to the time scale you think?
I would say the the pushback tends to come around not necessarily getting them from neurology to rehab, but around the time that they're on rehab, they hit about 2 weeks and we're asking for an extension of another week or so. And it usually ends up having to go to the level of an appeal. But once I get to talk to another physician and I have a firm plan in place, we get that extra time.
Thank you. Great job.
Anyone else got any questions?
Oh, Dr. Choudry, thanks for the presentation. I had a quick question regarding some medications that like might help neuroplasticity. I know like psilocybin was being studied a couple of years ago. I haven't heard anything about that since. And also, I think minocycline is something that you've used before. I don't know if you. I'm just curious on what the current literature is.
Yeah, the studies are still ongoing. It's kind of difficult to have large studies on those ones. We don't have anything going on here. I haven't seen it really used in clinical practice yet. The more common ones are maybe some of the things you see also in the TBI patients, like amantadine or methylphenidate, that might help with arousal to promote better participation. There's a lot of interesting stuff going on with these, I guess you could call them hallucinogens or what mind-altering drugs, but nothing in clinical use that I've seen.
Thank you so much for a great talk, Harris. This is Choudry Jan from Normalities, Shock Neuro Interventions. Quick question for you. I have two. One is, do we have any anatomical correlation or predictors of the rehab recovery process, or for prognosis, besides the clinical indicators, including the size and location of the lesions?
Yeah, size and location matter. I breezed through it a bit in my PowerPoint because I didn't want to get bogged down in it, but definitely it's in there. But essentially, right or left side will be worse. Cerebellar will probably be better as far as functional recovery, but we'll have higher fall risks, along with brainstem strokes tend to have more of basically communication and nutritional deficits, but recovery tends to be a little better as well.
Okay. The other question, thank you. And the other question I had is, what is your take on the virtual reality and immersion therapy that a lot of people are talking about these days? And what is your experience with that?
Yeah, I think it's a good extender of therapy. Where you run into the risk, and this is sometimes more in the outpatient setting, is it's used to occupy someone so that they can see other patients at the same time and not give that one-on-one that this patient might be needing. So like, if a clinic has 2 patients on VR, that therapist can bounce around to different people as well at the same time. Maybe that helps extend, I guess, therapy resources as well. But I think, at least in the acute and subacute settings, the one-on-one hands-on physical therapy should be the priority. And then things like VR should be used as an extension, something that we could have our CNAs or rec therapists be able to set up for people and train them in so that they can extend their therapy that way.
Thank you. Are there any approved programs or devices for VR to be covered by insurance that we can say maybe continue the therapy at home for patients?
Yeah, not much is covered yet. It's they're all very motivated trying to get the approval, but they need stronger research to support it.
Gotcha. Thank you so much.
Okay, well, if that's it, guys, I'm always walking the hallway. So if you have rehab questions or whatever, flag me down. I'm glad to talk to you all. We do occasional stuff that has overlap with neurology and academics. I usually let Srinath know. Always glad to have you guys come and see some of that stuff. And again, we have that 2-week elective and would be glad to have neurology people there to give them some insight from our side as well.
Thank you, Dr.
Thank you.
Choudry.
All right. Well, I think you have the slides. You can send them out. There's good stuff to review in there, and well, have a good day, everyone.
Thank you very much.
Thank you.